Coming back, and our session this next part is on venous thromboembolism and anticoagulation. And just to tee it up a little bit, this conversation came about partly because there are a lot of these kind of gray zone cases that we're faced with in primary care and in medicine about anticoagulation, and really wanted a forum to talk about some of those. And so I've invited Nick Burwick, and I'm going to let him say a couple words about who he is and about his role.
Yeah, thanks. Good to see everybody. So I'm Nick Burwick. I am a hematologist. I am primarily at the Seattle VA. May have seen some of you. I cover heme consults here and transplant. I see a lot of benign hematology and thrombosis and heme malignancy also. So yeah, these cases are great. I can help serve as discussant, answer questions, and looking forward to it. Nice
Cool.
meeting everybody.
Yeah. I think some of the learning objectives that we're hoping to cover includes some conversation about how you initiate anticoagulation therapy for venous thromboembolism. Really focused, though, a lot on this question about risks and benefits to provide patient recommendations to continue or discontinue anticoagulation for thromboembolic disease. To have some conversation about when low molecular weight heparin, unfractionated heparin, warfarin, direct oral anticoagulant therapy might be preferred, and to guide anticoagulation management around invasive procedures. And then at the very end, talk about some information resources that are available to you here at UW to help provide some information and resources to help you make decisions about anticoagulation. The format that we're going to do, you have the cases. There are 6 cases. We may not get to all 6, but what we're going to be doing is putting you into breakout rooms shortly. The cases that were chosen there don't always have a single right answer. All of these cases actually are real cases with some tweaks. I may have combined a couple of the details, but these are actually real cases. They don't often have a single right answer, and each one of them is going to involve some competing risks and benefits. And in these small group discussions, they're going to be short discussions, but I want you to really try to answer the questions that we're going to pose to you. When you return to the large group, I'm going to ask a spokesperson from each group to type into chat what your group came up with in terms of the recommendations to the questions that we have here, okay? And then we're going to invite you to say something about it. Perhaps we might call in some people to say something about it, but largely we're going to then ask Nick to give us his rationale and his thought process about why he might choose and what he might choose to do based on the cases. Okay, so with that, let's actually go into the first case. So you have the details of the case in front of you, but this is a 53-year-old man with hypertension, coronary artery disease, who's had left lower leg aching of 1 to 2 weeks, have some findings on lower extremity duplex scan that you can see there. And the questions in the small group are going to be, what do you do and how do you manage with these findings? And so should he be starting on anticoagulation? If not, what follow-up would you recommend, and would you give him some other treatment? And if you do anticoagulate him, which medicine, what route, inpatient versus outpatient, how would you start treatment on him? And thinking about your own continuity clinic, what resources can you do in your own continuity clinic in terms of follow-up? Okay, so with that, Javel, if you don't mind putting people into the small groups, we'll give you about 5 minutes or so, give or take, to discuss it in your small groups, okay? So go ahead and accept the invitation when it happens. Javel, are they getting, oh, sorry, go ahead, okay. Cool, like magic.
Just like magic.
Awesome. Javel, if you don't mind helping us keep track of time. So rough numbers, about 5 minutes for each case and 5 minutes for discussion afterwards. We'll flex that a little bit, but that's rough numbers.
My timer.
So John, you're probably, how many groups were they split up to?
8.
8. Okay. And you're sort of going to go around and see what each group has to say. Or
I think that what I'm going to do is probably back as people are trickling back in. If I can ask you all for someone from each group to type in your answers, or at least a brief summary of your answers to the questions on the screen there that were posed. Don't all do it at once. Yeah. Do not repeat ultrasound in 2 to 3 weeks. Okay. Other answers. You could go either way. Since it's below the knee, not extending into the popliteal, you can re-image. But since symptomatic, you could treat. Yes, anticoagulation because it's symptomatic. DOAC times 3 months. We thought this gentleman had distal DVT without risk factors for extensions. Okay, not to treat and repeat scan. Awesome. Lots of diverse answers here, which I think is actually a sign of a really interesting controversy and good fodder for conversation. So Anna Morenz, not Anna Shamtov, Anna, can you explain your group's thought process here? Because I'm interested in sort of knowing how you made this decision.
Sure. So we thought that he had a distal DVT because it involved the posterior tibial vein. We didn't think he had severe symptoms, but some other group mentioned that he was symptomatic, so you could consider treatment for that reason. And we didn't think he had risk factors for extension, such as a history of blood clot, like being immobilized or inpatient, current malignancy. So we thought it would be reasonable not to anticoagulate him for that reason and to follow up with a scan in a couple weeks. And then at that point, if there's evidence of extension, you would anticoagulate him. But one of our group members mentioned she would feel anxious not being on anticoagulation and being nervous about developing a PE. So I think there's also that's where the shared decision-making conversation with the patient is important as well. And I don't know off the top of my head, like what the risk is of developing a PE from a distal DVT.
Fantastic. So many great conversation points there. Nick, I'm going to actually ask you to weigh in here. As we start, I'm going to show a diagram of the veins here just to remind, because sometimes the nomenclature sometimes is confusing and it's a good reminder of basic anatomy. So Nick, if you could walk through your thought process on this.
Yeah, and first of all, that's a great question. I think these are all great answers. This is one where you said, there's not always a right answer. And I like all the answers about shared decision-making, risk versus benefit. That's always critical. It took me a while to wrap my head around the idea that not all clots have to be anticoagulated. And this really does get at the question of whether distal DVTs always need to be anticoagulated. And you guys are on top of it, but it's important to know the anatomy. We talk about the calf DVT, the cava veins, and the gastrocs and the soleals. This one was in the tibial. And then you have the perineals and the posterior anterior. And so it's good to keep that in mind when you're reading the report. This patient didn't have any evidence of proximal DVT. So we can go to the next slide.
Okay.
Oh, I'll speak up a little bit. Yeah. I speak softly, so let me know. You can look at the CHEST guidelines, and you guys touched on this in terms of what are the risk factors for progression. And I use these in my decision making. Actually, I was kind of surprised to see the D-dimer because I don't use it too often, but on the CHEST guidelines, they do suggest you could use the D-dimer if it's high. That's considered a risk factor. The ones I often do think about is the length of the thrombosis. Is it over 5 centimeters? This one went from the calf to the popliteal. That sounds pretty long, but if it's not on the report, you could also reach out to the vascular folks and try to figure out how long it actually was. And then whether it's actually approaching the proximal veins. I don't consider the popliteal a distal vein. I really consider it more proximal, right at the knee. So I think if it's approaching the popliteal, that's where I start to get nervous that it is probably a higher risk of propagation. Certainly somebody asked, the distal DVTs are much lower risk than proximal. And there's even a thought that the calf, the muscular veins are even lower, like the gastrocs and the soleus, whereas maybe the tibial are a little bit higher risk. So all those are potential factors. And you touch on the other ones: history of VTE, history of cancer, actually just inpatient status, bedbound. So all those factor in to decision making.
So Nick, to put you on the spot, would you anticoagulate this person?
Yeah, I think I would. So I mean, symptomatic, we're unlikely to find asymptomatic because we're probably doing the study for a reason. I think this guy, if I had to choose, I probably would, because it sounds like the size is fairly large if it's extending to the popliteal. I'd have to look at the actual report, but if it was and there wasn't clear provoking factor, I would. And then you have the question of duration. If you don't, I mean, you're exactly right. If you decided not to, high bleeding risk or for whatever reason, you really need to do a repeat ultrasound. That's standard to do it in a couple of weeks to make sure there's not propagation. It does provide some anxiety, and you have to make sure the patient can come back reliably and do that.
So if I can summarize your thought process here. So you're saying that because symptomatic and because there seems to be somewhat larger clot burden, that you would probably lean towards anticoagulating. And if you didn't, you would repeat the ultrasound in a couple of weeks just to see if it's propagated or developed further.
Yeah.
Okay, fantastic. Great. This concept of clot burden, I think we're going to come back to, but I think that in talking to you and your colleagues, I'm often struck by this idea that the clot burden actually is a part of this decision-making as you think through this, that larger clot burden actually pushes you more towards anticoagulation frequently and is a factor in your thought process. And so I think that it is useful for us to learn from that and read the reports, not just yes, no, that there's a clot there, but actually get a little bit more sense of how much clot there is in this process. Fantastic. Let's go to the next case. So in this case, this is a 46-year-old woman who has a new left lower lobe PE. She got started on anticoagulation, and in her case, she started on low molecular weight heparin, but went to warfarin. She's now 3 months post her PE. She's seeing you in clinic. Her INRs have been therapeutic, but she says to you that it's been inconvenient. And she's here to see you in clinic now to ask about how long she needs to be on treatment. And you see here some factors associated around the time of her clot diagnosis. And in your small groups, go ahead and discuss. These are some questions that I'd like you to go over, which is, should she continue anticoagulation therapy for 3 months, longer than 3 months, and how long? And are there any further tests that would help you? And what would you choose for anticoagulation if you were to continue therapy? So go ahead and go back in your small groups and discuss this.
Okay, we'll give them about 5 more minutes.
Back. Again, just like last time, if you could put into the text what your group's thoughts are. This again was the case. And then just to remind you, here were the questions that we asked. So go ahead and put into the chat what your group's decision was about whether to continue anticoagulation, if you want other tests, what choices you would choose if you were to continue. I'm not seeing, oh great, indefinite anticoagulation, up to date on age-appropriate cancer screening. 3 months total with 1 month D-dimer follow-up, or after discussion, consider indefinite DOAC. Shared decision-making. We'll give that everyone gets shared decision-making as part of this process. You don't get any points for that. Do age-appropriate cancer screening and determine if unprovoked. Great. I'm going to ask Nikki to comment, and then I'm going to ask Jonathan to comment, because both of you came up with somewhat different answers. And so if you could each sort of give your group's thought process on indefinite anticoagulation or 3 months total. So Nikki, if you could sort of.
Yeah, I obviously do not know all of the literature about this, but I had a patient in clinic who had an unprovoked DVT, and there was a great academic half day a couple of weeks ago about provoked versus unprovoked clots, and that a 5-hour drive from Spokane probably wouldn't be something that would provoke a DVT. And my understanding, and one of the members of our group was looking kind of at the data a little bit, that the risk of recurrent clot, even in the absence of any kind of identifiable hypercoagulability on lab testing, the risk of recurrent clot is actually pretty high. I think that thing was like 15% in 1 year and like what, almost 50% in 5 years. Maybe it wasn't that high. But so that means that for many patients, after they complete kind of a course of anticoagulation, they really should be, obviously with shared decision-making, like continued indefinitely, just because the risk of recurrent clot risk is so high. I have also read, related to this patient I had with an unprovoked DVT or a PE, that you can do some D-dimer testing. My understanding was it was longer than 3 months, and that can help determine kind of long-term risk. And there is also some data around using half dose apixaban kind of for long-term prophylaxis. But I know that some of that is a little bit more nuanced, and I would probably use a hematologist to help me.
Great. And then thank you for sharing that conversation. Jonathan, do you want to share your group's thought about 3 months total with 1 month D-dimer follow-up?
Yeah, I mean, the question is, what does the patient want? What is the patient's risk of bleed? So you're weighing indefinite anticoagulation with the risk of bleeding, as well as some risk factors for repeat, with the risk factors for her being the PE over a DVT. And, well, female sex, I think, is prevented in this case, but I don't think either answer is wrong. And it'll come down to what the patient wanted. And it sounds like the patient is annoyed of anticoagulation at this point, although DOAC could be a much better choice for her.
Yeah, great. I'll ignore the questions about how far away Spokane is and with the weather or not. But Nick, do you want to weigh in on your thoughts on this?
Yeah, a lot of that was really spot on, I would say. So she's now at 3 months here. In terms of plane travel or flight or car travel, I think over 4 hours, you do start to think about it. You really do want to pin down the history of how long was it? Did they get up and take breaks? But I mean, in general, regardless, it's really considered a weak provoking factor. I think it is fair to actually say unprovoked, but if we're having a conversation with patients and say, well, okay, you did have this, but it's really, the reason we do indefinite is because it's really a weak provoking factor and the high risk of recurrence. So I would favor indefinite if there's not high bleeding risk and patients tolerating it well. I would not do additional thrombophilia workup other than age appropriate cancer screening. Our decision for duration is really based on provoked versus unprovoked. And so I favor indefinite regardless. And then, so this is, thanks for putting this up. So this gets at what somebody brought up, is that the true unprovoked, then you're talking about, if you stop anticoagulation, about 10% risk of recurrent clot just in the first year, and then that goes up to 20%, even higher over 2-3 years. And these non-surgical factors are more in between. I don't know that I count car ride, but if you have someone with OCPs, their risk isn't zero, even though you consider it provoked. It is probably unmasking some underlying thrombophilia. But surgery is a one case. That's a very strong provoking factor. You can feel pretty confident that their risk of recurrent VT is low. Next slide. And this is a nice table here. It'll serve as a reference in terms of strong, moderate, and weak. You can see the weak risk factors. That includes bed rest, like hospitalization or immobility due to car plane travel. So those patients really consider the same as unprovoked. Next slide. So this was it's PAD-SPE study. This was one of the studies that really changed our thinking about indefinite anticoagulation. This was patients who had first unprovoked PE, got warfarin. Well, each group got 6 months anticoagulation. Then one group went to placebo. The other group got an additional 18 months, so 2 years total anticoagulation. But as soon as they stopped anticoagulation, even after 2 years, they caught up to the placebo group within a couple of years. So that's an argument for indefinite anticoagulation. Next slide. And this case, the reason I put this slide up, this looks at long-term risk reduction with lower intensity. Somebody mentioned half dose of apixaban. So that's right. So this patient is 3 months. I'd probably give her another 3 months of full dose anticoagulation, either continue warfarin or switch her to a full intensity DOAC. And then after that, this patient is a great candidate for low intensity dosing with apixaban or rivaroxaban at these doses, either 2.5 BID apixaban or 10 milligrams daily rivaroxaban, which is half the full dose.
Nick, is that is the half dose there then to also help reduce the risk of complications, bleeding events? Is that the idea behind the half dose? So you get protection, but also reduce the competing risks? Is that idea?
So it definitely reduces the long-term risk. It's really secondary prophylaxis compared to placebo or compared to aspirin. The bleeding risk was sort of non-inferior, so there's slight reduction, probably absolute reduction in bleeding risk. It's not dramatic, but even if you could cut it just even slightly, I think it's worth the trade-off. So I do try to get patients onto the low dose.
Okay.
Prevention is the best. This patient already had VTE, but just to mention, we talked about any flight or travel over 4 hours, you should start to think about it. Does the patient have underlying risk factors that maybe you're missing? There are patients who ask, they want to go on a long plane ride and are asking if they should take something. And people who are high risk, you can recommend either just compression stockings, which there's some data for, or actually just a 1-day dose of DOAC, like just 1 day of prophylactic rivaroxaban, like a 10 milligrams on the day of the flight. I've done that occasionally with people who are deemed higher risk. So that, there's not a lot of data for that. There's some data with Lovenox, but extrapolating for that, some people do a 1 day of travel anticoagulant.
I'm looking at the slide here and remembering to give breaks during academic half day because of the computer-related seating immobility. And looking at the bottom, there are 2 hours without getting up. So I think we're okay. There's some questions in the chat. Hasib is asking about why not do a thrombophlebitis workup if she comes back positive with APLS. Wouldn't you want to know if you need to use warfarin? What are any comments or thoughts about that?
APS, it comes up all the time now because of TRAP study, and there's more data coming out showing that that warfarin is superior to DOACs. I do not check everybody for APS. And a younger patient that might be more likely to do it. Somebody who has other signs or symptoms of antiphospholipid syndrome. This patient is more on the younger side. I never think it's wrong to do it because if it's positive, especially if she has multiple positive APS antibodies, then you would continue warfarin. So I don't do it in everybody, but I've been doing it more frequently for that reason, because you would stay on warfarin.
And this patient was on warfarin. Can you remind us, because this comes up periodically, about what tests are impacted by warfarin and what in terms of workup for hypercoagulable factors?
Yeah, so I would not do genetic thrombophilia screening in general, so you don't have to worry about that. And the genetic test wouldn't be influenced anyway, but like the protein CNS would. So the ones you really worry about, the lupus anticoagulant, really you can't send it, or I don't, on warfarin or on DOAC. I send the ELISA-based assays, the anticardiolipin antibodies, antiphospholipid panel. Those are ELISA-based, so they're not influenced by the anticoagulant. And you're really trying to rule out high-risk APS. Those are the patients that don't do well with DOAC. So if those tests are positive, then you have your answer. But I would avoid sending the lupus, because what's going to happen is it's going to be positive, and it'll be hard to interpret.
Yeah, the dreaded positive test that you don't know anything, you don't know what to do with. Julie, it looks like we answered your question, correct? So if not, then put it back in the chat again. Let's go on to the next case. So this is a case of a 62-year-old man who has a history of smoking, type 2 diabetes, and hypertension, and has a right lower extremity DVT. And you can see there the result of the scan and where that is. It's been treated with warfarin, and the patient was found to have colorectal cancer. And there is a need and necessity to do surgery on this patient because of the colorectal cancer. And the question is, 9 weeks into warfarin therapy, how do you help his surgeons manage the anticoagulation around the time of surgery? There's a time pressure here because there's a blockage of about 75% in lumen. There's worry that there's going to be complete obstruction. So the surgeons want to work with you on how to manage this perioperatively. And so go ahead and we'll put you in the small groups, but here are the questions. What is the role of cancer screening after new thromboembolism? How do you recommend management of his warfarin and colonoscopy prior to the treatment for his colorectal cancer? How would that management differ? He's on warfarin if he was on rivaroxaban instead. Would you keep him on warfarin? Would you change him to something else? And for this, what would you do perioperatively? Okay. And go ahead and we'll put you in your small groups.
Just a quick note, if your internet has bounced you off and you've rejoined, we'll be in a different breakout room. Just note that.
Boy, okay, welcome back. I hope you had a good discussion. So here are the questions again that came up as a result of this case. If you need the questions or the case again, let me know and I can hop back to it. But this is the person who has colorectal cancer, and what do you do about that? And so if you can, again, throw into the chat what your group came up with in terms of what to do about this clot and the surgery coming up. I'll also preface while you guys are typing that this is a complicated case. This is something that we do see though, and this comes up all the time in perioperative medicine. I'm hoping the silence means that it's a long answer that you're all typing in.
Can you repeat, Dr. Choe, which of the questions do you want us to answer right now?
Any, all, whichever. Or if you want to just unmute yourself and just say, that's fine too. Here they come. Okay, age-appropriate screening, bridge to heparin, given recent VTE. Would you change to something else? So low molecular weight versus DOAC instead of warfarin. Great. Question Gabby asked, doesn't rivaroxaban have higher risk of bleeding for GI malignancies compared to other DOACs? Wouldn't want to continue that if so. Okay, some questions about specific DOACs. Yeah. Any other comments about the specifics around the management around surgery? I see Jonathan's groups answer that. Any other bridging? I knew what you meant, Julie.
I'm just going to talk. I think that the bridging is actually a little more, I don't know. I don't feel as strongly as some of these other people about bridging. This person has been treated for 9 weeks. It's a DVT, not a PE. And I wonder if like the warfarin question, maybe you want to bridge back up, but just like to come down. I don't know. I'm interested to hear what the data says.
Nikki, are you saying that bridging may not be necessary? Is that what the bottom line of what you're saying?
Yeah. Yes.
Okay, great jumping point for discussion. Yeah. Julie, since you put bridging into the chat, can you give your group's thoughts about this, or are you willing to?
Yeah, actually, so if you all can click, if you go to the chat and if everyone can just click on what Anna Feiss put up, there's this is a really nice algorithm, and this is printed out in a lot of our team rooms, but it describes who should be bridged peri-procedurally in the hospital. Yeah, you can click on it. And this is like this is something that we do a lot on the Jerry service. So those of us that have done the Jerry service have had a little bit more experience with this. But it's kind of nice because it shows AFib, VTE, mechanical heart valves, etc., and then just low EF. And so you basically look at what constitutes high risk, moderate risk, and low risk. So a VTE within 3 months is considered high risk, and you would use bridging. It's a grade 2C evidence for it, but our institution would use bridging for that. If you consider somebody a moderate risk, then you can kind of make your decision, and for low risk, then you don't bridge. So I think that this person would go into a high risk category. Because of the timing, you also could potentially make a case that because of his active cancer, that he would get another point, although I don't think that that's on this risk stratification guideline.
Yeah, sorry, the print is very small, but the link is useful. I appreciate your sharing this. This was going to be something that, not this particular page of it, but I was going to at the end share some of these online resources and where to find them, because there's a ton of information that we have actually through our anticoagulation services that's incredibly useful for you to use. Great conversation, great discussion. let me go back to the slides here.
And big shout out to my amazing NICU intern, Anna Feiss, for sharing this with our group and then allowing me to describe that.
Yeah, and thanks for the thanks. Nick, do you want to give your thoughts on great conversation, great discussion. Nick, what are your thoughts as you hear and think about this case?
Yeah, great discussion. So the first one's easy. I agree with age-appropriate cancer screening. Unless, of course, somebody has some localizing symptoms. How would you recommend managing this warfarin? I mean, I would second and third what folks are saying. I use the UW anticoagulation guidance like all the time. And then if you go by that, you're also aligned with our institutional practice. And I think it generally aligns with national practice also. So I think because this person's under 3 months is considered high risk, I agree cancer's not on there, but that also provides additional risk, which would make me lean towards bridging with Lovenox. Because on rivaroxaban, we can talk about that. That doesn't require bridging. It doesn't require a hold for 1 or 2 days, depending on what you consider his bleeding risk. For a biopsy, might not be that high, but for a colectomy, that would be high. So we can talk about that. Bridging anticoagulation. So when we talk about bridging, it's really, we're talking about warfarin to low molecular weight heparin. You touched on this table. This basically is pulled from that table that you just showed, VT within 3 months versus 3 to 12 months, and then versus over 12 months. The one that's a little bit trickier is history of recurrent VTE. And not all histories of recurrent VTE are created equal. So sometimes you have somebody who had one at age 20 and then at age 60, and there's 40 years in between. And sometimes you have one where the person had a breakthrough where they stopped anticoagulation, it again right away, or they're homozygous for some genetic mutation. But a lot of patients with recurrent VTE I just consider high risk because they've already approved clotted multiple times, and I lean towards bridging. So that's so I use that table all the time, and I go with that. So this is just an example. This is again on the anticoagulation website, but the idea behind warfarin is that you're going to try to get them down to a subtherapeutic level. You're going to start low molecular weight heparin. Surgeons will have a pre-specified INR level. So if you can get below that level, if you're not, you can consider vitamin K. You may have to consider whether they have some underlying dietary insufficiency or liver disease if you can't get there. And then resume warfarin, low molecular weight heparin based on post-operative status.
Yeah, I would just jump in and say that this is one, if you were asked this question in your future practice or in your current practice, I would have an active conversation with the surgeons. I think this resumption of warfarin in particular, depending on the risk, knowing that there is a period in which they're going to be subtherapeutic, I think that's the conversation with the surgeons about how long do you think that they're at higher risk of bleeding and when can we restart this? And this is usually a conversation and not something set in stone.
I agree. This is data from AFib, but it was a really nice, just simple study. It was called the PAUSE study. And you held a DOAC either 1 day for low risk and 2 days for high risk. And then the DOAC was room 1 day after for low bleeding risk and 2 to 3 days after for a high bleeding risk procedure. And the outcomes look good with just a nice, simple approach. Next slide. Of course, kidney function plays a role. This is from the UW guidelines. And so you may hold for 2 days for those with the reduced GFR or 72 hours for those with high risk bleeding procedures. And for patients on end-stage renal disease, I've held up to 5 days for patients going in for a procedure. So you have to take that into account.
It's tiny print and it may not show well, but the table does give you a little bit of guidance about what high risk and standard risk are. So it doesn't reproduce well, but you'll be able to see it if you pull up the website.
Yeah, perfect. And
oh, here it is. Yeah.
These are just some examples, but I agree. You're probably going to have to go for whatever specific procedure it is, but major surgery, hip or knee replacement. Actually, polypectomy is on there. I mentioned that because it was like you have a patient going in for colonoscopy, you can make it a polypectomy. That's actually under the high bleeding risk category. And you can see if it's just more of an endoscopy and biopsy that is considered low risk.
Do you have a reaction when you get a question from an ophthalmologist about minor eye surgery about anticoagulation?
Mm-hmm. And I consider cataract surgery low risk also.
Yeah.
Yeah.
It does periodically come up in primary care where we're asked to sign off on that. Okay.
This, what did I want to do with this? Oh, yeah. So for cancer-associated thrombosis, this came up. This patient, I think, sounds like started on warfarin. Lovenox has been historically favored over warfarin. This was based on the CLOT study. Recurrent thrombosis or breakthrough thrombosis is much higher in cancer than it is in non-cancer patients. If you look at this, recurrent VTE, 9% even on low molecular weight heparin, 17% on warfarin. So there's a high degree of breakthrough in these patients and a higher risk of bleeding. And if you look at the non-cancer studies, it's much, much lower. So these patients, even with appropriate anticoagulation, have breakthrough events. So this showed superiority of Lovenox over warfarin. So this led to the studies of Lovenox versus DOACs. And this is the data here. This nice review, you can see the references there. In general, DOACs have showed improvement in terms of risk of VTE, but there is a trade-off with increased bleeding risk, particularly for GI cancers that was mentioned. So actually this patient does have a GI cancer. So whether you would maybe do low molecular weight heparin, problem is most patients don't like to be on an injectable for too long, but maybe you would start with that and then switch to a DOAC depending on how they do in terms of bleeding symptoms. So you do have to have that discussion with the patient about thrombotic versus bleeding risk, because there's a little bit of a trade-off.
This is a relatively recent shift. I think as recently as just even a couple of years ago, patients were being discharged off the surgery services following oncologic surgery on long periods of injectable low molecular weight heparin. And so that was pretty common. And so this is only a recent shift in our practice patterns. Great. Any other questions aside from Hasib talking about selective blindness to printouts in team rooms? Any other questions or comments about this case? Hasib, I'm going to print out all sorts of things and put them in front of you and put them in your box. Great. All right, let's move on to our next case. So this case is a patient with recurrent VTEs on chronic anticoagulation, has had very variable therapeutic levels, has, among other complicating factors, very unstable housing, and has had recurrent PEs. And today presents with sharp pleuritic chest pain, and CT angiogram shows segmental PE in the right middle lobe and subsegmental in the left lower lobe. And so the questions for your group's conversation is, how do you manage his PEs now? And what would you do to manage the anticoagulation therapy in the future? Is there any changes that you would make? So go ahead into your breakout rooms. We'll probably give you a little bit less time on this one, just in interest in getting a couple more cases in, and we'll come back and again ask you to share. So go ahead into your breakout rooms. Down with printouts and team rooms, only memes allowed. Social media beasts. Awesome. I think we have a few more seconds left. While everyone's coming back in, as you come back in, please do the same. And again, please type in your group's conversation or answers to the cases, to the questions. Is that everyone? Okay, great. Welcome back. So again, please go ahead and put this in. Great, Becca, indefinite rivaroxaban, DOAC once a day. DOAC, okay. So far, 2 votes for DOAC. Any other counter arguments or counter plans besides DOACs? Oh gosh, troponin, BMP, echo, then DOAC versus heparin. Wow, you pulled out everything. Okay, we weren't sure about the cost of DOACs in this patient. Okay, so DOACs, but some concern about some of the pragmatic issues. Okay, Jonathan, do you mind sharing? I'm going to ask one of the groups about their DOAC answer, but Jonathan, what were your thoughts about all of this going on there? There's a lot in your answer there.
The first treatment split is inpatient versus outpatient, how aggressive we need to be, and that'll determine based off the right heart strain. I mean, not exhibiting.
I got it.
Yeah.
Okay,
Um,
so really just stratify, you wanted those tests. I understand your thinking now. Okay, got it. Molly, if you could share, it sounds like your group was thinking about DOACs, but you had some concerns about DOACs. Could you unmute and give your group's thoughts there?
Yeah, I think if, kind of in a black box, we would favor a DOAC, preferably a rivaroxaban once a day for this guy, because it sounds like he hasn't had maybe perfect adherence with his warfarin. But for someone who is undomiciled and perhaps doesn't have insurance, I don't know if that person would be able to afford the cost of that medication, in which case you'd be prescribing something that they can't take. So we discussed actually talking with a pharmacist to see what cost of various options would be before making a decision.
Yeah, clearly cost is important for this whole formula, given some indications of possible variable adherence. Did any group not want to go to a DOAC? It seems like every group went to DOACs. Feel free to unmute yourself. Did anyone say, let's continue with warfarin? I see a lot of head shaking no's. Okay. Nick, what are your thoughts about this case?
Yeah, so he needs anticoagulation. I guess that's a question of warfarin versus DOAC. I think, the old teaching was you don't switch just because of non-adherence, but I think that, I think in this case, if there is some concern about dietary inconsistency, I mean, that elevated INR makes me think that maybe that's part of it if the vitamin K levels are fluctuating, which, so the DOACs might be better for that. But you're right, they have a short half-life. So if there's not adherence, he's going to be higher risk of breakthrough thrombosis. So it'd be helpful to tease out adherence is critical, but I like DOACs, better safety profile, no dietary interactions. And you're not going to have that super therapeutic INR. If anything, you probably underdose rather than overdose with those. So yeah, I guess I'd also favor a DOAC in this situation. Rivaroxaban versus Pixaban. Rivaroxaban is once a day, so sometimes that's good for patients just because of simplicity. Pixaban I do feel is slightly safer, but it's a BID drug.
Can I take a thread of something that you just said there, though, and make sure that we highlight it? That one of the issues about DOACs, because it's a short half-life, we also have to take into consideration that, yes, we then have less worry perhaps about overdosing, but there's also then a competing risk of underdosing, because if intermittent adherence is there, that because the fast on and fast off, that there are periods where they're going to be off. And that's also one of the weighing considerations about that warfarin sometimes has some advantages in that case too. But that in balance, you're saying that you would favor still the DOACs because of the overall safety profile. Did I capture some of that correctly?
Yeah, I think so. And I mean, obviously, we're not monitoring the levels. That it brings the patient into the system. You can get here at the VA, we get anticoagulation pharmacy plugged in, whether somebody's on a DOAC or whether somebody's on warfarin. Our anticoagulation pharmacy, if we tell them a patient we're more worried about, they may be more likely to reach out to the patient more frequently, at least at the beginning. It's sort of a toxicity adherence check. So it depends on what your institution has for supportive services in terms of
I think that we have to worry a little bit that that there actually is an advantage to frequent views, right? Like, so the INR check, as inconvenient as it is, and as it puts a lot of pressure on patients, also provides a view into what's actually happening. So the fact that the patient is missing INR checks would raise a little bit of concern in my mind about are they actually taking the medications, and what are the implications of perhaps missing a lot of doses of the medication. So I think that this is actually, although we all said DOACs, I think it's a fairly complicated scenario. And I think we all said that we need to talk to the patient and get more information about what are the barriers What were the issues
Yeah, because it
involved?
does sound like he's pretty well compensated right now in terms of his mental health and is well sheltered. So I just want to watch us, like, assuming that someone who's undomiciled might have poor adherence, and that, like, I would probably miss some INR checks with my schedule. So,
Yeah.
but one other thing I wanted to say was, I feel like on the cardiology service, there's some doubt that the pharmacokinetics of rivaroxaban is like that it's actually a 24-hour medication, and that people might also be underdosed because it might not actually be appropriate to be dosing rivaroxaban once a day. I didn't know if Dr. Burwick, you had a thought on that.
Based on the pharmacokinetics of the rivaroxaban, is that what you're saying? Yeah, I actually hadn't heard about that. I mean, the one I do think about that for patients who are over 120 and definitely over 140 kilograms that were underdosing. I mean, you can do anti-10A levels, like rivaroxaban levels, as opposed to worried. I sometimes do that if somebody has a breakthrough and I'm worried that they're getting underdosing. I have to read more about that. That's super interesting about the pharmacokinetics. I don't know a lot about that for the once a day.
Yeah. And Annie, thank you. I know this was highlighted, but thank you for highlighting our making sure that we're not anchoring and making assumptions based on prior behavior too. I think that's very important. Seems like a big pharma choice to brand yourself as the once per day DOAC. Yeah, perhaps. Nick, do you want to talk through, we have a couple slides here about how to assess bleeding risk. Do you want to talk through?
Oh, yeah, I was wondering if this question was also getting at assessing bleeding risk, and it's nice to be very objective about this when you can. A lot of the bleeding calculators are based on atrial fibrillation, and so there is a VTE bleed one. I like to calculate numerous different bleeding scores, but you can see here, actually, I'm trying to look at this patient, I think male patient. It sounds like he does have poorly controlled hypertension, so I think he gets a point for that. But reading through the question doesn't sound like he has other factors. So you could argue that this may not be a barrier for him here. Prior bleed always gets you a couple points on these scores. So if you look like the has bled or the hemorrhages score, if you go to the next slide, you can see they have some additional factors like alcohol use and making falls risk and these things that can be a little bit more subjective, but can give you an overall picture of pros versus cons. And in terms of, I think it tends to be more relevant for atrial fibrillation. Most patients with VTE need anticoagulation, but even then, sometimes you're weighing pros versus cons.
Yeah, I'm struck by the prior slides that none of them are necessarily super great either. That they're that they all have some limitations, but I think that having a tool like this is useful to systematically go through and think about the risks of bleeding. Andrea had a question here. Do we always need a loading dose for DOAC?
Yes, I would say yes. For a new VTE, I always do the loading dosing initially. Now you could do, if somebody's high bleeding risk and they're inpatient, occasionally we'll start with a heparin drip for close monitoring, and then you sort of can just back calculate the number of days they were on heparin drip and then complete the DOAC loading. You don't need to restart the loading. But other than that, I do the full thing.
Right. In the interest of time, we're going to go to the last case. We're going to skip the next case and go to case 6 and have one more conversation. So case 6 is 86-year-old woman, multiple comorbid issues, who's been on chronic warfarin therapy for more than 2 decades. Her family is talking about moving her to an assisted living facility because of increased inability to care for herself. And her family wants to discuss anticoagulation. Is there an alternative to warfarin? It's been difficult to bring her in for INR checks. And so what do you recommend for her medications? Would you continue her chronic anticoagulation therapy, and why or why not? We'll keep this discussion relatively brief, just maybe 3 or 4 minutes, and put you in breakout rooms. Thank you. In the interest of time, does anyone want to unmute themselves and share what your group actually came up with for this case about this older woman?
I think we were concerned about her falls and about her being on 3 different agents because she's on clopidogrel, aspirin, as well as the warfarin. So we would obviously want to talk to cardiology, but I think given the PCI, that was a while ago, we would consider stopping the clopidogrel, maybe keeping the aspirin, then doing a DOAC. Because of a renal function, we were thinking probably apixaban would be best. Alternatively, if cardiology wants her on Plavix, and we'd probably want to stop the aspirin, because my understanding is we always drop the aspirin off in that situation. So I think that's where we were. So she's still high risk because of her falls, her age, and then we calculated her Has blood, which was, I think I got 3. She only got a point for age, other meds, and hypertension, because her renal disease doesn't qualify yet.
Man, I'm super impressed with how much you covered in just a short period of time of conversation. That's awesome. I think you have the heart of a geriatrician. The answer is always reduce the number of medications is always the right answer. Nick, do you want to give your thoughts about this case?
Yeah, I agree. I'd like to talk to cardiology and try to get them off the dual antiplatelet therapy. Certainly the triple dual antiplatelet plus full dose anticoagulation is not recommended, although in the DOAC studies, they were often allowed to be on either aspirin or Plavix. So I think it was like about 10 to 12% of those studies patients were on an antiplatelet agent. So that bleeding risk is sort of baked in terms of some of those studies and remains pretty low. But that, yeah, dual antiplatelet plus full dose make me really nervous. But yeah, I think we should try, if somebody has VTE history, to keep them on anticoagulation. I think this question often comes up because for atrial fibrillation, there are dose reduction guidelines for older age, lower body weight, and creatinine, but those guidelines we don't use for venous thrombosis, where we do try to give the full dose. Although if it's been over 6 months, like we talked about before, she could be moved to low intensity dosing. So that's another option.
I think if you wanted to say as a group that shared decision-making conversations with the patient and the patient's family, that's never going to be the wrong answer. So I think that's probably a helpful place to start. We're over time, so I just want to leave with a couple of references. Nick's going to put into the chat a link to the CHEST guidelines. CHEST guidelines are always helpful for recommendations regarding venous thromboembolism. Also, I'm gonna, one place that was mentioned, the Anticoagulation Services website at UW is tremendous. And I, in full disclosure, never can remember the link to it, but Google is your friend, and you just type in University of Washington anticoagulation. The first link there is for the Anticoagulation Services. And this is a screenshot. I think that they've changed and updated a little bit of the look of the screenshot, but you can find every question that you're wondering about somewhere on this website. Now, the website itself is not the most intuitive website. There's a lot of links on here that you have to dig a little bit, but there's a lot of stuff around perioperative management. There's a lot of stuff about specifics about various oral anticoagulants and choices. There's some patient sheets that you can print out for, when to stop warfarin, when to start low molecular weight heparin, those kind of things. So a lot of bridging papers in there, handouts in there. It's a very, very helpful website. You just have to poke around a little bit. We didn't get a chance to cover case 5. The brief summary of case 5 is filters. If you have to use, or try not to use filters, because they over time can raise risk of long-term clot risks. If you have to place a filter, have a plan to remove the filter once the acute phase is passed. Feel free to look at the case, and we're happy to talk more about it after the end of the session, but I think those are the main teaching points. So key learning things: unprovoked clots, lots of risk of recurrence of clots. Anticoagulations have risks, but studies have said that the risk might be low. Low dose DOACs are reasonable options. DOACs can be effective for cancer-associated VTEs. I think you can see the rest of this. We're gonna stop here, and if there are any last-minute questions, feel free to throw them in the chat or unmute yourself. But I want to take this opportunity to thank Dr. Burwick for being our expert discussant on this, and hopefully these cases are helpful for you for the controversies that inevitably come up with thromboembolism. And have a great rest of your day.